Hello and welcome, class. My name is Melissa Bragg, and I will be presenting acute stress disorder. I'm going to start out with the introduction. Acute stress disorder is a trauma and stressor-related disorder. When an individual goes through a traumatic event, then they might develop a trauma and stressor-related disorder. ASD is a disorder where an individual is exposed to a traumatic event and exhibits short-term symptoms similar to PTSD. Other trauma and stressor-related disorders includes reactive attachment disorder, disinhibited social engagement disorder, post-traumatic stress disorder, adjustment disorder, other specified and unspecified. Acute stress disorder is caused when an individual is exposed to an event that's related to death, a threat of death, or violence. The exposure to a threatening event could be direct or indirect. An example of indirect exposure is a police officer might suffer from symptoms of ASD after seeing a bad car crash that resulted in another person's death. This is indirect because the police officer was not in the car crash, but he witnessed that someone else died in the car crash. Another example would be learning that a friend was killed in a shooting. An example of direct exposure is a student got shot during a school shooting. Who's at risk? Females are more likely to develop acute stress disorder. Sex-linked neurobiological differences in stress response may contribute to females' increased risk. Also, women might be exposed to more traumatic events than men, for example, sexual assault, domestic violence, and rape. Individuals with a history of prior trauma are also at risk. We have a physiological response to stressful situations. When the body is under constant stress, we have elevated reactivity to stress. Individuals with elevated reactivity are at risk for developing acute stress disorder. Lastly, individuals with prior mental disorders are more likely to develop acute stress disorder. According to our textbook, the symptoms of acute stress disorder fall into 4 categories. The first category is intrusive symptoms, which includes flashbacks and constant thoughts or memories about the traumatic event. These intrusive thoughts are recurrent and involuntary. Second is dissociative symptoms. These dissociative symptoms can be feeling numb or detached from others. Third is avoidance symptoms, avoiding situations that might serve as reminders of the event. Fourth is hyperarousal symptoms, which can be sleep disturbances, irritability, and problems with concentration. These symptoms can last for days, or they can last for up to a month. I want to point out that according to the DSM-5, there's actually 5 categories. Our textbook did not include negative mood as a category, and that's why it states that there's only 4. In the DSM-5, negative mood is the second category, and there's only one symptom, which is persistent inability to experience pleasure or happiness. Clinicians can interview the individual to assess their symptoms and conclude a diagnosis. In Richard Bryant's book, Acute Stress Disorder, he discusses various assessment tools created to identify an individual's symptoms. I have 2 examples. First is the ACID. This interview is made up of yes or no questions that ask questions related to diagnostic criteria of ASD. Second is the Acute Stress Disorder Scale. This scale has an individual report how severe each symptom is. Next, I'm going to talk about a form of treatment called psychological debriefing. According to Bryant, psychological debriefing is used to assist individuals who have recently witnessed a traumatic event. This is done by helping the individual with coping and is used as early intervention, which reduces the likelihood of an individual developing ASD. The sessions last 3 to 4 hours, and the individual discusses their trauma. This is why there's issues with psychological debriefing. Discussing one's traumas directly after they experience a traumatic event could be harmful. Trials suggested that the techniques of psychological debriefing needed to be changed. Individual therapy encouraged individuals to talk about their trauma before they are ready to. This is why psychological debriefing was changed to psychological first aid. Psychological first aid was very similar to psychological debriefing. However, they focused on reducing harm and helping the individual cope. Psychological first aid also focused on making sure that the individual has their essential needs, such as food, and that they have a really good support system. Other psychological treatment modalities. Cognitive behavioral therapy includes psychoeducation, anxiety management, exposure, and cognitive restructuring. Psychoeducation has been shown to help individuals with ASD. Individuals who go through CBT show less signs of avoidance, anxiety, and disassociation. Additional types of psychological treatment includes decompression, battle-mind debriefing, and psychological recovery skills. Decompression was used in the military and includes having time off to relax before individuals are sent back home. Battle-mind debriefing is a skill-based approach and focuses on helping the individual associate their traumatic experiences as the past. Next, I'm going to discuss prevalence and comorbid disorders. Prevalence of acute stress disorder is prevalent in less than 20% of cases following traumatic events. The following comorbid disorders are related to acute stress disorder: depression, panic disorder, substance abuse disorders, and anxiety disorders. Depression is the most common comorbid disorder with ASD. ASD could be associated with these disorders because the individual had a pre-existing disorder or because additional disorders were developed around the same time of the recent trauma. Post-traumatic stress disorder is another disorder that has a close relationship with acute stress disorder. ASD and PTSD are very similar because they have a lot of the same symptoms. Both ASD and PTSD happen when an individual is exposed to a traumatic event. Acute stress disorder and PTSD are separate disorders due to their differences. ASD symptoms last for no longer than 30 days, and if those symptoms persist, then it can be diagnosed as PTSD. Dissociative symptoms is a category within ASD, while PTSD has a specific subtype for an individual who's exhibiting those symptoms. Lastly, I'm going to go over a quick reflection. Acute stress disorder is a short-term disorder that doesn't have a lot of awareness like PTSD does. If more people were aware of acute stress disorder, then individuals who've been through traumatic events would be more likely to reach out for early intervention. This would lower the amount of PTSD cases as well.